Welcome to Impact Medicom's podcast. I'm your host, Anna Christofides. In this episode, Dr. Michael Chu discusses an important paper by Dr. Abramson and colleagues on the management of peripheral neuropathy associated with Brentuximab Vedotin in the frontline treatment of classical Hodgkin lymphoma. Dr. Michael Chu is a medical oncologist at the Cross Cancer Institute and an assistant professor at the University of Alberta in Edmonton, Alberta. Hope you enjoy it.
Hello, everyone. My name is Dr. Michael Chu. I am a medical oncologist treating lymphoma and myeloma at the Cross Cancer Institute in Edmonton, Alberta. Today, we're going to be discussing the management of peripheral neuropathy associated with Brentuximab Vedotin in the frontline treatment of classical Hodgkin lymphoma, as published by Dr. Abramson and colleagues. My disclosures include honorary from AstraZeneca, Janssen, Roche, Sanofi, Gilead, Pfizer, Takeda, BMS, and Amgen, with research support from BMS and Janssen. In terms of background, as many of you know, Brentuximab Vedotin is an antibody-drug conjugate targeting CD30, which is commonly expressed on Reed-Sternberg cells in the classical Hodgkin lymphoma. It is tied to a chemotherapeutic agent called monomethyl auristatin E, or MMAE for short. MMAE is, in fact, a microtubular inhibitor, and so as a result, has a very classical side effect profile, including that of peripheral neuropathy. Brentuximab Vedotin has demonstrated significant improvement in progression-free survival as overall survival in combination with chemotherapy in the frontline setting when compared against the traditional ABVD. To be fair, BV has had, in fact, a demonstration of impact both in terms of response and long-term remission at multiple different lines of therapy for classical Hodgkin lymphoma. So as you are quite familiar with, it has been demonstrated in a phase 3 clinical trial in advanced disease for untreated stage 4 disease and has demonstrated the ability to also prolong responses and remissions following that of stem cell transplant. Peripheral neuropathy with respect to Brentuximab Vedotin is a significant toxicity associated with microtubular inhibitors. So to be fair, it is a degree of a class effect and not just something exclusive to Brentuximab Vedotin. So that's part of the reason why there's a substantial amount of experience with it, just simply because it is very similar to other chemotherapeutic agents that cause neuropathy, such as docetaxel, paclitaxel, vincristine, and vinblastine. Peripheral neuropathy can lead to significant dose reductions, treatment delays, and early discontinuation, and obviously can impact the quality of life of patients. The peripheral neuropathy related to brentuximab is quite variable, but common enough that you're likely to see that as practitioners. The rate of peripheral neuropathy in Hodgkin lymphoma treated with BV through clinical trials and worldwide experience ranges from anywhere from 9 to 73%. In the Echelon 1 clinical trial, the rates were 67% in Brentuximab Vedotin in combination with AVD. After 6 years of follow-up, 72% of patients were affected by peripheral neuropathy had resolution of the complication. In real-world analyses, BV with AVD was reported in 75 to 80% of patients, including up to 10 to 12% with grade 3 or moderate to severe peripheral neuropathy. The sensory version of peripheral neuropathy is by far the most common version of the toxicity as compared to, say, motor. In terms of mechanism of action, the peripheral neuropathy is likely a complication of, again, the microtubular inhibitor function of the chemotherapy itself. What happens is most likely the disruption of axonal transport of the neurons between neuronal cell bodies as well as distal nerve endings. Hence, that's why the most common of which is obviously to the extremities, so fingers and toes in particular, and then potentially more proximal complication as the toxicity persists. How to manage peripheral neuropathy in this case is limited. So the guidance is predominantly based off of other chemotherapeutic agents. And so there's been less of a guidance in regards to how to handle that with Brentuximab Vedotin. So the authors of this current paper that we're reviewing today convened a virtual meeting to discuss their personal experiences as well as to review the evidence regarding how best to recognize and manage it. And that led to the summarization that they then put into the paper that we are going to review. In terms of assessment of peripheral neuropathy, The biggest question, of course, is how to recognize it, number one. So in terms of what types of motor neuropathy or sensory neuropathy it can impact, and then as well as the gradation in terms of severity. So as I mentioned earlier, the most common peripheral neuropathy related to this class of therapies, including that of BV, is a sensory neuropathy. The clinical scenario of this is numbness and tingling, so a sensation change, but it can also include that of a neuropathic pain, more so in terms of a burning or what other patients will describe as an electrical discomfort that can start in the fingers and toes and migrate more proximally. Other manifestations include that of proprioception loss, so in other words, an inability to feel the location or position of the body parts, the most common of which patients will describe as just feeling unsteady on their feet. That can overlap significantly with ataxia, though ataxia, to be fair, is much more of a cerebellar abnormality, but I find that the proprioception is probably more common in that scenario. Motor dysfunction is described, so motor dysfunction would be more so of a weakness, again, more so towards the distal body parts. Hyperreflexia is described, though I suspect that's more so the loop that is being interrupted. So in other words, where the sensation of the stimulus is not being felt, that will not trigger that of a reflexive action. In terms of gradation, this is based off of clinical trial experience, so the CTCAE grading system, version 5, of which obviously then there are multiple gradings. Though to be fair, the differences in peripheral neuropathy grading between the versions has not really changed significantly. So as you see here, it's a 4-point grading system, with grade 1 being asymptomatic, grade 2 being moderate, grade 3 being severe, and grade 4 being life-threatening. Now, the interventions typically happen around grade 2. So the easiest way that I think of it is that if something needs to be done either in terms of interruptions or that of actual management of neuropathy, that typically would be that of grade 2. Grade 3 is where really it starts to impact substantial things on the day-to-day living. So the activities of daily living, some of those would include that of personal grooming, bathing, dressing, walking, things that they need to do on a day-to-day basis. In terms of questions of what to ask patients, much of that is based off of, again, the common things or the impact on their day-to-day living. So again, with the peripheral neuropathy and the sensation being the biggest issue, the easiest question is whether or not they're having any numbness or tingling, particular to their fingers and toes, and how far does it extend? Does it go farther up more proximally towards the hands or even up the arms in very severe cases? Is it associated with the pain, as I mentioned earlier, with the shooting pain or the electrical or fire type sensations, as that is very much different from that of nociceptive pain? And what impacts does it have on their daily living? Are they having difficulties with day-to-day things? I usually like to start asking with dexterity things. So can they write with a pen or pencil? Do they have problems tying their shoelaces, buttoning a shirt, brushing their teeth? In this day and age, a very common thing that they have difficulty with that they point out is the inability to use their phones for text messaging. And what risks do they have for neuropathy? So peripheral neuropathy with respect to BV is certainly amplified for patients that have increased risk of neuropathy to begin with. Those are patients that have pre-existing medical conditions such as diabetes that can lead to neuropathy. Oftentimes that neuropathy from diabetes can be subclinical and then become much more appreciable when other insults are being put towards their nerves, such as Brentuximab Vedotin. Management of the peripheral neuropathy when it does present itself is quite variable. And I think that's part of the reason why that this discussion was prompted in the first place, and obviously the position paper thereafter. So the recommendations are set forth from a combination of personal experience as well as that of what was done on clinical trial. What was done on clinical trial is much more summarized in the manufacturer's recommendations, and so the easiest of which would be dose modifications or interruptions. The dose modifications essentially mean a drop in the chemotherapy dose, and so the dosage of Brentuximab Vedotin is 1.2 milligrams per kilogram to a maximum of 120 milligrams in combination with chemotherapy. It typically is administered every 2 weeks to a maximum of 12 doses, matching that with AVD for 6 cycles total, with treatment being every 2 weeks. And when grade 2 occurs, so in other words, where it is moderate and impacting to a limited degree their day-to-day living, the reduction is down to 0.9 milligrams per kilogram or a maximum of 90 milligrams, but continuing that of every 2 weeks. So it is a substantial drop in the overall dose. When things get more significant up to grade 3, the recommendation is to hold Brentuximab Vedotin until it improves down to grade 2 or less. And then when it comes to restarting, to consider restarting at that same lower dose at 0.9 milligrams per kilogram every 2 weeks, still with a maximum again of that of 90 milligrams. But some experts recommend continue to hold that as opposed to waiting to restarting at grade 2 neuropathy, waiting until it goes all the way down to grade 1 neuropathy first. The other consideration would be to either dose reduce or remove other chemotherapeutic agents that could be contributing. Remember that with AVD, the V is vinblastine, and vinblastine, as I mentioned earlier, is a classical chemotherapy that is associated with peripheral neuropathy as well. And of course, with a very severe or grade 4 neuropathy, the recommendation is to discontinue Brentuximab Vedotin, much of which is very similar to that of the initial studies of use of Brentuximab Vedotin in later lines of therapy with classical Hodgkin lymphoma. Now, in terms of the author's recommendations, when Dr. Abramson and colleagues were discussing this, the thought was to essentially focus in on trying to remove risks of other neuropathies. And so, again, thinking that of the vinblastine, so, in fact, they actually would endorse an earlier management strategy in intervening a little bit more upfront. So, for example, with that of grade 1 neuropathy, their thought was to reduce either Brentuximab Vedotin or vinblastine without a specific recommendation in terms of how far to go down on. And part of that, again, is based on personal experience. And so, with respect to chemotherapeutics such as docetaxel and vincristine, oftentimes there'll be a gradation where at grade 1, as opposed to being a larger drop down to 0.9 milligrams per kilogram, for example, they will try to drop down by, say, 10% or 20%, much of which is gleaned on either the individual practitioner's personal experience or that of judging based on what the patient is describing and detailing with their neuropathy. When it comes to grade 2, the authors would recommend either holding one or both drugs until the toxicity goes down to grade 1. And then to grade 3, they would recommend stopping either one or both drugs until neurologic recovery and resuming most likely one as opposed to both treatments, and again with a reduced dose, much like it was recommended in the author's recommendations. I think the biggest takeaway there is that the authors, and much like my own practice, would recommend a much earlier intervention. Now, why would that be the case? Well, the concern, of course, is for the risk of long-term peripheral neuropathy, which can occur. Now, in the previous slide, I outlined that in the clinical trial evidence that the large majority of patients had an improvement of the neuropathy or complete resolution following cessation of therapy, but that still left nearly 30% of patients that were left with long-term toxicity, and that's a substantial proportion. So the earlier intervention likely reflects that concern for long-term neuropathy and trying to head that off. And so I think that the dose reductions in grade 1 is a very sound recommendation. Dose interruptions and dose delays are obviously not ideal simply because there is other clinical trial evidence with ABVD that demonstrates that dose interruptions and dose delays may have an impact in the long-term remission of the cancer itself. So ideally, we'd like to try to keep pushing with the treatment in order to try to balance the risk and the benefit. What about other management strategies? Most of that was talking about how to interrupt or reduce the doses of the chemotherapies. Well, there are pharmacologic agents, and much of which has been used in other disease entities leading to peripheral neuropathy. So in this case, drugs such as gabapentin, pregabalin, venlafaxine have been tried. Duloxetine, in fact, has been tried most with clinical trial placebo-based studies. And so duloxetine is featured significantly in various guidelines because there was clinical trial empiric evidence that it did improve patients' neuropathy, and that was dosed at anywhere from 30 to 60 milligrams in divided doses. Supportive management, so physiotherapy, occupational therapy, acupuncture has been described, obviously counseling patients and doing some additional things to try to stimulate those nerves. Oftentimes I will tell patients, and being in Canada, to avoid severe cold temperatures as that can exacerbate the peripheral neuropathy sensation. So staying warm in the wintertime is an important recommendation. On top of that, making sure that they continue to stimulate those nerves is an important thing to try to improve upon long-term recovery. So I often will tell them to use a stress ball and play with it, either just rolling it in their hands or actually actively squeezing it to try to, again, stimulate those nerves, particularly when they're sitting and resting. For example, watching TV is a very common one. Risk reduction, so trying to remove other exacerbating factors. So as mentioned earlier, diabetic neuropathy is a very common pre-existing condition that can lead to a peripheral neuropathy after the use of these agents such as BV. And so trying to optimize their glycemic control would be a very easy and obvious step in order to remove those risks. So in summary, for recommendations for peripheral neuropathy, the range of management options include that of dose reduction, or adjusting the chemotherapy in general. So dose reductions is obvious in terms of reducing the intensity and the dosage of the Brentuximab Vedotin. Alternatively, because vinblastine can cause neuropathy as well, that can also be targeted as either something to be dose reduced or potentially removed if the severity of neuropathy is high enough. Other pharmacologic interventions include that of duloxetine, pregabalin, venlafaxine, though the most clinical trial evidence supports that of duloxetine compared to that of pregabalin or venlafaxine, or gabapentin for that matter as well. Non-pharmacologic interventions or supportive measurements are something very easy to recommend and something that is easy for them to start early on, particularly if they start showing signs of grade 1 toxicity. Minor interventions, things such as avoiding cold temperatures, extreme cold temperatures, particularly in Canadian winters, as well as other things as was described, such as acupuncture, reflexology, physical therapy, and occupational therapy. Physical therapy, as I mentioned, or something that they can easily do themselves, are using things like a stress ball in terms of stimulating those nerve endings, either in their hands or in their feet. From my perspective, really, I think that the biggest takeaway is that of earlier detection and clinical suspicion. So knowing that the Brentuximab Vedotin can lead to peripheral neuropathy in a high proportion of patients is important to obviously ask patients to reveal those problems earlier on. As I'm sure much of you have seen or experienced, some patients are very concerned about revealing some of their toxicities as they're worried that will then remove their ability to receive potentially life-saving therapy with chemotherapy. But the biggest thing, of course, is to warn them of the potential for long-term peripheral neuropathy if it is not recognized early enough, or if it gets into a high enough severity where it is very difficult to then manage thereafter. That is actually more of a risk of removal of therapy for safety reasons, and that can have an impact in long-term remission, of course. So the key is to obviously ask patients all the time and to be mindful of the possibility and to intervene earlier if need be. Use of a neurologist or referral to a neurologist is something that was not discussed too significantly in the paper, and part of it is just because much of the interventions that neurologists can provide are medical therapies that have very little clinical trial evidence apart from duloxetine, as mentioned. However, I think that having a neurologist involved can be helpful, particularly for those that have very early development of the neuropathy, or for those that have early development of severe neuropathy with grade 3 or higher toxicity. I think that a neurologist opinion is not a harmful one that can help with respect to other management strategies, or even open up some thoughts on other physical therapies that can help out. Easiest early steps would be dose interruptions. Dose reductions, particularly earlier, as the authors have recommended in grade 1, I think is a very astute thing to do. Certainly, as opposed to dropping from 1.2 down to 0.9 milligrams per kilogram, by recognizing in grade 1, dropping it by smaller amounts may head off the toxicity while allowing for a better dose intensity, ultimately, of the chemotherapy. But delays in treatment are certainly worthwhile as well for those that have a much stronger impact of the peripheral neuropathy. So either with that of delaying the use of vinblastine, or also that of Brentuximab Vedotin. Medical management is somewhat controversial, as you can kind of tell based on how the paper somewhat dances around it to a degree, but also with respect to the listing of different therapeutic options, but really focusing that of duloxetine. So again, duloxetine at 30 to 60 milligrams as a daily dose divided over the course of that day has clinical trial randomized trial evidence that improves patient-reported outcomes. So the key metric that they used was something called the Brief Pain Index, or BPI. And so certainly that with the statistically significant improvement, it would support that of duloxetine. Now, they gloss over some of the other therapeutics in the paper, though, to be fair, pregabalin has trial evidence as well in the breast cancer setting. But again, that would be with the use of drugs such as docetaxel and paclitaxel as opposed to Brentuximab Vedotin. But pregabalin seems a reasonable alternative in an extrapolation of clinical trial evidence, with much less evidence supporting that of things like gabapentin and venlafaxine. So I don't think that I want to focus too strongly on just duloxetine, as there are other therapeutic options. Is it wrong to try gabapentin and venlafaxine? No, but I think that the clinical trial evidence is a little bit lacking to support that. But certainly in a case-by-case basis, or if there's extenuating circumstances, that can be considered. So in summary then, I would like to highlight that peripheral neuropathy is quite common with Brentuximab Vedotin. So the earlier intervention or the earlier recognition is important. Certainly the use of other supportive measures such as physical therapy, occupational therapy, and the use of non-medical interventions, I think is something that is very safe and easy for patients to have a go at, and would allow for patients potentially to continue on with Brentuximab Vedotin in combination with chemotherapy for frontline classical Hodgkin's lymphoma. I'd like to thank you for your attention and thank you for your time in listening in today.